Dear Professor Gerosa, dear Stephen, dear audience, it took me a hard time to prepare this talk. And the topic, selecting the appropriate candidate, was very difficult for me, in fact, to prepare, since Michael Morshois did talk about a couple of those topics I will raise in a minute. Let me start with a case presentation. It's a 60-year-old male admitted to our hospital with ischemic heart disease, status post-3 vessel CABG, 10 or 12 years ago. He was listed for cardiac transplantation 6 months before due to his cardiac failure. And now he's admitted to our center with severe heart failure, stabilized on IV positive inotropic support. The additional information is that his blood group is 0 and he's tall, more than 190 centimeters. So I wonder and would like to ask into the audience, what do you think is the correct treatment strategy for this patient? Is it continuous medical therapy and wait for transplant, most likely on the high urgency list, or do you go for VAD implantation? You should keep that in mind, and I will ask you at the end of my talk about the case and want to follow up on this particular patient.
So again, everybody who thinks that the patient should be VAD implanted with a VAD can raise their hand. So the vast majority of the audience would think that the first therapeutic option would be better.
Okay, let's see at the end of the talk. We have heard already, and everybody knows, that cardiac transplantation offers excellent results. And looking on the ESHLT data, you have a survival after 10 years of more than 50%. Depending on the device location, the LVAD offers this day excellent results too, with a survival after 12 months of support of 70 to 80%. And depending on the device location, if it's BiVAD or total artificial heart, the results become more poor. Therefore, cardiac transplantation stays the gold standard for patients with terminal heart failure, comparing actual survival rates. However, that might become therapy of choice if transplant is not predictable due to specific contraindications and the organ is not viable due to emergency situation or donor shortage. Cardiac contraindications for transplant are clear, like pulmonary vascular resistance, advanced end organ dysfunction, and so on and so on. And I don't want to get into detail. Urgency requiring immediate treatment refer to patients in cardiogenic shock. These are the so-called crash and burn patients, like patients with acute who present with acute myocarditis, with acute decompensated chronic heart failure, post-cardiotomy failure, and non-tractable ventricular arrhythmias. Let me talk about 5 examples of so-called crash and burn patients which we have treated recently in our hospital. To give you an example, this is a 15-year-old patient with acute myocarditis. We did treat him with a BiVAD and we were able to wean him. The same, it's an 18-year-old patient with intractable ventricular arrhythmias. We could support him on a biventricular assist device, paracorporal assist device, and were able to wean him also. And there was a 16-year-old girl with an acute decompensated chronic heart failure, which we were able, after biventricular support, to transplant successfully. And another 43-year-old lady, after a post-infarction cardiac failure, we put in an LVAD assist device and were able to transplant. However, I can continue in this list. At the end, these are all young patients with no other treatment options, and the selection might be simple for lack of alternatives. But what about the others? Patients with chronic heart failure and continuous clinical worsening. Patients who are usually admitted to the transplant center or vet center after failure of non-surgical treatment of our colleagues, the cardiologists, with optimized medical treatment after CRT system implantation, with recurrent cardiac decompensations and slight but progressive end organ dysfunction. Criteria have been developed to help optimizing patient selection. However, there's no consensus guidelines for vet implantations until these days. Risk scores try to identify predictors for survival and guide patient selection, and we have talked about this already. However, none of those risk scores, and this is an example of the Münster group recently published in the Journal of Heart and Lung Transplantation, none of those scores are prospectively validated. And they are limited to specific devices, like the one recently published in 2009 by Holman, and the scores they derive in general from very small patient populations. Based on the Intermix registry, the Intermix defined 7 clinical profiles for patients selecting and for timing of that implantation. And this diagram gives you an idea about those 7 categories. The first is the so-called crash and burn patient, and I have given you a couple of examples already. These are patients in acute cardiogenic shock, and you have to treat them within hours. The category 2, profile 2, is a patient sliding on inotropes. And here you have to find an intervention and treat those patients within of days. And so on. You continue with Intermix level 3, dependent stability, 4, the frequent flyer, 5, housebound, until 7, the patient who is in NUA class 2 and 3 and does not need intervention yet. Looking at the outcome of patients according to these Intermix levels, we can recognize that survival in the group 1 and Intermix level 2 is very poor, with only 40% of survival after 2 months of support, comparing to a significant better outcome in patients who are at the Intermix level 3 to 4. In addition, there are a couple of other factors determining the appropriateness of that implantation. And this is a figure from a nice publication from Wilson, who did present this recently in Circulation. And he raised the question that there are, besides risk factors and besides indications, a couple of cardiovascular considerations and non-cardiovascular consideration you have to put in mind before selecting the appropriate patient. These are, for example, valvular diseases. You cannot implant a left ventricular assist device if the patient has an incompetent aortic valve or mitral stenosis. If so, you might have to change or put in a competent valve, or in case of or in the rare case, you might be able to occlude it while the patient is on the assist device. And this gives you a nice example of our hospital where we put in an LVAD in a patient. However, he developed severe aortic incompetence shortly after, and we were able to implant an occluder in the left ventricular outflow tract. You see that here in this slide. This gives you the echo. This is the occluder in the outflow tract just under the native aortic valve, and we were able to treat his ongoing cardiac failure once he was on assist device. And there are other cardiovascular considerations like right ventricular function, and Dr. Wiesenthaler will talk about this in a minute, which is very important. Arrhythmias, intracardiac shunt. If there is a shunt on the foramen ovale, you will have to occlude it prior to implantation of the assist device. Or if the patient has ischemic heart disease, you will have to bypass the right coronary artery prior to LVAD implantation. However, there are a lot of non-cardiovascular considerations like nutritional status, renal function, the neurologic function as discussed before, multi-organ failure, body size, and the psychological and psychiatric conditions which are very important. If the patient is not able to take care of himself after implanting an assist device, you have to reconsider if this is appropriate for this for your patient. Hepatic dysfunction was discussed already from Michael Morschois here again, coming from an old publication. If you have total bilirubin if the total bilirubin rises more than 0.3 or 4, the mortality becomes significantly higher after that implantation than in a group with lower bilirubin. Let me follow up on the patient I did present in the beginning of my talk. Again, this was a 60-year-old male with ischemic heart disease, now admitted with severe heart failure, stabilized on IV inotropic support, and with a blood group 0, and who is very tall. So we are in the dilemma that the decision has to be taken further to await donor organ despite clinical aggravation, or perform that implantation. And this deprives the patient firstly for transplantation. And at the end you have to consider that patients who fulfill the high urgency status are already in a state with decreased outcome after that implantation that refers to Intermex level 2 or 2+3. This is what we have done in Freiburg. We did implant an LVAD, HeartMate 2 on the left side. We did assist the right side temporarily with a Ventricular and were able to successfully transplant this patient's 4 months of support. I want to conclude. There are no consensus guidelines for VAD implantations yet. The understanding of cardiac and non-cardiac risk factors optimize the VAD therapy, and VAD registries help, like the Intermex registry, help improving selection of VAD patients. Thank you very much.
Can you please have the slide, the discussion? Is now open for discussion, this paper?